afternoon, Professor and colleagues. It's my pleasure to be here with you with very eminent speakers in this session. I am sure that we will all enjoy the talks, so I prefer that to start immediately. Professor Ahmed Adam will start.
It is my pleasure to introduce Professor Hunaymat from Jordan. He is actually Egyptian more than Jordanian, I think. And we love him so much. Has many positions. Of course, the head of the Jordanian Dialysis and Nephrology Association. And he will introduce a very important subject with HIF versus EBO in dialysis and CKD patient. Please, Professor Hunaymat.
Assalamu alaikum wa rahmatullah, and it gives me great pleasure and honor to be with you again and again. Thanks to all my sisters and brothers in the Egyptian Society of Nephrology and Transplantation, in particular Professor Magdi Sharqawi, for inviting me to this important meeting. Professor Magdi gave me the task of talking about HIF versus EPO in CKD and dialysis. Now I'll make few slides introduction about anemia and guidelines for treatment of anemia. We all know that anemia is common, and according to the WHO, 30% of the world's population have anemia. Copart published a nice paper in April 2020, and he concluded that up to 54% of pre-dialysis CKD patients and up to 90% of dialysis patients have anemia. We know that also a quite good number of cancer patients have anemia. We all know this slide that anemia is much more prevalent with worsening renal functions. So if we're talking about stage 1, then 10 to 15% of the patients will have anemia, while in stage 4 and 5, up to 80 and 90% of the patients will be anemic. Now, we also know that the prevalence of anemia is much more among diabetic CKD patients than those without diabetes for so many reasons. These are the most common causes of anemia in CKD patients. Of course, decreased erythropoietin production from the kidney is the commonest, followed by absolute iron deficiency. Then the less common causes like blood loss, short red cell survival, bone marrow suppression, B12 and folate deficiencies, bone mineral disease, and high hepcidin levels, inflammation, infection. So these are some of the causes of CKD anemia. Why treat? Because in the so many studies done on anemia in CKD is associated with a poor quality of life. It is associated with a reduction in energy and exercise capacity, reduction in neurocognitive function, more left ventricular hypertrophy, and in most of the studies, there is an increased mortality as a result of anemia. Remind ourselves of normal erythropoiesis in the bone marrow, stem cells, precursor and progenitor cells, 2 weeks from pluripotent until pro-erythroblasts, which needs erythropoietin. This takes 14 days, and then a week from pro-erythroblasts into mature red cells, so a total of 21 days, and the last week needs rapid iron uptake. On the cellular level, we all know this, that the EPO gene stimulates the production of erythropoietin from the kidneys, liver, lung, and etc. And this interacts with EPO receptors, leading to red blood cell maturation. Now, the expression of erythropoietin gene is inhibited, as you see, by GATA2 and nuclear factor KB. and it is stimulated by hypoxia-inducible factor, which is HEF. Now, on the EPO receptor, there are drugs which act here, stimulate EPO receptor or alter EPO receptor interaction, and there are also drugs which act after the EPO receptor, so between EPO receptors interaction and red blood cell maturation. So many guidelines, as you all know, for the management of CKD anemia. I'll take the last one, which is the Renal Association Clinical Practice Guidelines on Anemia of CKD. These guidelines were in fact released in June 2017, and they are valid for 5 years. So until June 2022, unless a breakthrough, of course, happens in the management of anemia. So guideline 1 is we should measure hemoglobin in CKD grade 3 at least once a year, and twice a year in patients with CKD grade 4 and 5, not yet on dialysis. If iron is depleted, then we should replace iron. And iron depletion is defined as hypochromic retic count percent less than 6%, retic hemoglobin more than 29 picograms, ferritin more than 100, or something between 100 and 500 micrograms per liter, and transferrin saturation more than 20%. And ESAs, we all know that they are indicated in CKD patients who are likely to benefit in terms of quality of life, physical function, avoiding blood transfusion, and in particular, patients who are ready or are going for transplantation. Now, a strong recommendation that the decision on the choice of ESA is based on the local availability. So all ESAs are the same. This is 1B. Now, ESA's recombinant human erythropoietins were approved by the United States Food and Drug Administration in 1989, and they are since then helping our patients in terms of increasing hemoglobin levels, less need for transfusion, and improving quality of life. However, they do have their own side effects and risks. They increase the incidence of thrombosis, they increase cerebrovascular events, and in some cases, there is an earlier requirement for kidney replacement therapy. This is just to illustrate that all ESAs are the same. The first is recombinant erythropoietin, darbepoetin, sera, which is the long-acting, and the EPO-mimetic peptides, all act on the cell membrane JAK2 receptors to send a signal transduction and then gene activation for the maturation of red blood cells. In 2018, KDIGO updated their recommendations on and guidelines on the treatment of CKD anemia. And as you see here in red brackets, in initiating and maintaining ESA therapy, we recommend balancing the potential benefits of reducing blood transfusion and anemia-related symptoms against the risks of harm, in particular stroke, vascular access loss, and hypertension. This is 1B. And we recommend using ESA therapy with great caution in patients with active malignancy and in patients with a history of stroke. This is also 1B. And even in patients with a history of malignancy, this is weaker. Now, treatment with ESA, the target hemoglobin when treating with ESA is something between 10 and 12 grams per deciliter, and we do not recommend more than that. We can go down to 9 grams per deciliter, but not less. The dose of ESA, we start usually with 25 to 50 international units per kilogram, 3 times weekly sub-Q, and monitor hemoglobin every 2 weeks until stable on target, then monthly. The initial dose of ESA should be in the lower range, which is 25 to start with in patients with history of thrombosis or in patients who are having uncontrolled blood pressure. fits or recent history of cancer. Then we should titrate the weekly dose on monthly basis by 25% ups or downs according to the target we're looking for. So the target is something between 9 and 11 up to 12, not more. With more, I mean, more than 12, increase the risk of cardiovascular diseases and mortality and closure of the fistula. These are some of the potential mechanisms for increased cardiovascular risk with higher target hemoglobins in ESA studies, increased viscosity and endothelial damage, increased platelet activation or platelet function, extreme hemoconcentration, increased blood volume, blood pressure, and the toxic effects of increased iron treatment. Now, resistance to ESA, we all know it. We recommend that inadequate response or resistance to ESA is defined as failure to reach the target hemoglobin levels despite a sub-Q ipopaitin of more than 300 international units a week if sub-Q, or 450 international units per week if intravenous, or darbepoetin dose more than 1.5 micrograms per kilogram per week. Now, causes or how to evaluate patients with suspected ESA ESA resistance. We should look for inflammation by measuring C-reactive protein. We should always check for hyperparathyroidism. We should check for trace metals, though rare, particularly aluminum, but KT over V is mandatory, so adequacy of dialysis, and then recheck for other causes of anemia, such as folic acid and vitamin B12 deficiency. There is no recommendation at all for measuring anti-erythropoietin antibodies among CKD patients regularly treated with ESAs, unless there is a sudden decrease in hemoglobin concentration at a rate of 0.5 to 1 grams per deciliter per week, with the normal platelet and white counts with an absolute retic more than 10,000. And there is a recommendation that all ESA therapy should be stopped in patients who develop ESA-induced pure red cell aplasia, and the patients will go back to transfusions if necessary, and some will need immunosuppressive medications guided by the level of anti-EPO antibodies. Patients on ESAs should be carefully monitored for side effects. The commonest, we all know, hypertension, thromboembolism, pure red cell aplasia, increases in extracorporeal circulating residual blood volume, and last but not least is probably a solid organ tumors. So these are some of the pivotal clinical trials in CKD anemias. The first is a normal hematocrit study, which was published in New England Journal of Medicine more than 20 years back in 1998. Two groups of patients, a total of 1,200 patients divided into low hematocrit group, which is 30, and a normal hematocrit group, which is 42. And of course, the study was halted, as you remember, when the differences in mortality between the groups were recognized as sufficient to make it very unlikely that continuation of the study will reveal a benefit. So there is more harm, higher mortality in the normal hematocrit group than in the low hematocrit group. The COIR also, we know it, a bit larger number of patients, 1,400. It's an American study in the US only. Ipopaitin alpha, the randomization was also high target hemoglobin 13.5 or low target hemoglobin, and the conclusions were that there is an increased risk when targeting a higher hemoglobin 13.5. Strong trends for death, higher rates of cardiovascular and all hospitalization, no improvement or no better quality of life, higher number of adverse effects. So the recommendations were a lower hemoglobin. Same CREATE 600 pre-dialysis patients, early and late intervention, The same almost conclusions: increased risk with targeting higher hemoglobin, higher number of dialysis initiations, and this is the first time mentioned. There is little improvement in the quality of life, but no benefit in left ventricular hypertrophy. The trial was on darbepoetin, 4,000 patients, 2,000 in each arm, darbepoetin or placebo group, and it unfortunately it was disappointing because there is a higher stroke rates were documented in patients on darbepoetin with higher hemoglobins. Locatelli, where he wondered, will there still be a role for the originator ESA agents after the biosimilars and the HIF stabilizers? And he concluded that there will be a definite rule for HIF stabilizers in the near future because they have an on-target and an off-target effects. Since they improve the cholesterol, they reduce blood pressure, and they have a positive effect on decreasing cardiovascular events. So HIF factors, are they friend or foe? They're friends in terms of increasing the production of EPO. They decrease the level of hepcidin, so anti-hepcidin, and improve chronic inflammatory status. A potential benefits on improving total cholesterol and blood pressure. This might lower the effect on CKD patients, decrease cardiovascular risk in CKD patients. Therefore, in terms of appropriate activation of the HIF is associated or might be associated with an exacerbation of fibrogenesis and deterioration of kidney function, and on the long run we don't have idea so far. So HIF stabilizers, pros and cons summary, they're given orally. This is advantage over EPO with possible avoidance of supraphysiologic EPO and iron concentration. They improve iron utilization because they act as anti-hepcidin. They improve blood pressure, improve lipid profile. They reduce the progression of kidney disease because they decrease inflammation, and they might protect against ischemia. While the possible side effects are some increase in pulmonary artery pressure, they might enhance the growth of renal tests and some few reports on tumor progression. So ESAs increase hemoglobin concentration, reduce transfusion requirements, of course, and they helped us since 1989. They helped our patients in stabilizing CKD anemia, but they have their own risks. They increase cardiovascular events, vascular access thrombosis, and increase blood pressure. While HIF stabilizers, they are a new class of agents for the treatment of CKD anemia. These work by stabilizing the HIF complex, resulting in an endogenous erythropoietin production, and these improve iron mobilization to bone marrow. They are administered orally and more favorable route for patients not undergoing hemodialysis. So by inducing considerably lower but more consistent blood erythropoietin levels than ESAs, HIF stabilizers may be associated with fewer adverse effects, so less cardiovascular effects than patients on EPO. So this is my last slide to conclude that anemia is common in CKD patients, and it has so many causes. There is a strong impact of anemia on morbidity and mortality. Multiple guidelines almost are the same. Future treatments are promising, and HIF stabilizers, I think they have an advantage over all other medications because they have first, they induce the body's natural erythropoietin, which makes a smoother hemoglobin increase, and that will might result in less side effects. They also act as anti-hepcidin, and they have favorable effect on cholesterol and cardiovascular events. Again, thank you very much for having me with you. Thank you.
much, Professor Ghunaymat. Very interesting lectures, and I hope you will stay with us for the coming 1.5 hours, because the discussion will be the end of the 4 lecture, and then we'll shift to the second speaker, Professor Mustafa.
I'm a pleasure to introduce my colleague, Dr. Tariq Antawi. He's a senior consultant of nephrology in Garbeya. He has a PhD nephrology in Shams University. He is also Vice President of Garbeya Nephrology Association. Welcome, Dr. Tantawi.
Many thanks for the kind invitation to participate in this eminent Congress. And my address today about skin examination, an important diagnostic tool in CKD. Careful examination of the skin can provide crucial clues to diagnosis of chronic kidney disease position and aid in the monitoring complications. A high prevalence of cutaneous disorders is expected because most patients with CKD have an underlying disease process with cutaneous manifestations. Uremia and the conditions associated with renal replacement therapy are fraught with numerous and relatively unique cutaneous disorders. Dermatological manifestation of renal disease may be divided into 3 general categories, including dermatological manifestation of disease associated with end-stage renal disease, or manifestation of dermatological manifestation of uremia, dermatological disorders associated with renal transplantation. Diabetes mellitus is the most common cause of end-stage renal disease, with a lot of dermatological manifestation, including diabetic dermopathy, necrobiosis, lipodystrophy, acanthosis nigricans, eruptive xanthoma, Carlos disease, scleroderma. Many cutaneous disorders are associated with diabetes mellitus, including necrobiosis, lipodystrophy, diabetic colon, eruptive xanthomas with diabetic retinopathy. Other characteristic dermatological manifestation include scleroderma, acanthosis nigricans, and Carlos disease, and the cutaneous changes related to pruritus. Diabetic dermopathies could correlate with the initial involvement, including retinopathy, neuropathy, and nephropathy. Systemic lupus erythematosus also can present with a lot of dermatological manifestation, including berbera, chronic spontaneous lupus, subacute lupus, photosensitivity, and etc. Lupus erythematosus may be classified into 3 subsets, including chronic cutaneous lupus erythematosus, may be devastating and disfiguring cutaneous disease, but significant systemic involvement occurs in less than 10% of patients. Subacute cutaneous lupus erythematosus, a higher percentage of patients have systemic involvement, but severe renal disease is uncommon. Systemic lupus erythematosus, mucocutaneous abnormalities occur in 85% of patients and may involve skin, hair, and the mucous membrane. Henriksen-Lyon berbera, granulomatosis with polyarteritis, polyarteritis nodosa, and subacute bacterial endocarditis also present with a lot of dermatological manifestation. As regards granulomatosis with polyarteritis, skin involvement occurs in about 14 to 77% of patients, and is associated with a higher frequency of renal involvement. Cutaneous lesions include berbera, subcutaneous nodules, and ulcers. The histological findings have been described, including leukocytoplastic vasculitis and granulomatous formations. Leukocytoplastic vasculitis is more common and associated with bulbar berbera, a more aggressive course, a high frequency of renal disease, and overall poor prognosis. As regards polyarteritis nodosa or periarteritis nodosa, may be subclassified either systemic or cutaneous. Cutaneous lesions are reported to occur in about 50% of patients and include livedo reticularis, ulceration, and subcutaneous nodules. Up to 50% of cases with systemic polyarteritis nodosa were associated with hepatitis B virus infection, and about 40% of cases with cutaneous polyarteritis nodosa have been associated with hepatitis C virus infection. Cholesterol emboli, hepatitis C virus, and HIV also are characterized by a lot of dermatological manifestations. For example, cholesterol emboli may affect organ. However, the skin antigens are affected most commonly. Emboli can develop spontaneously or follow an invasive vascular procedure such as arteriogram. Embolization may occur either shortly after the procedure or many weeks later. The continuous signs of cholesterol emboli, including livedo reticularis, petechia, purpura, and Bluetooth skin biopsy, may readily reveal diagnosis. For hepatitis C virus, is the most common cause of essential mixed cryoglobulinemia. The most common cutaneous manifestation of cryoglobulinemia is palpable purpura, resulting from the immune complex mediated leukocytoclastic vasculitis. Other cutaneous manifestations of hepatitis C virus, including porphyria cutanea tarta, lichen planus, necrolytic acral erythema, and cutaneous changes associated with chronic pruritus. HIV, cutaneous disease, occur in 60 to 100% of patients infected with HIV. Seborrheic dermatitis is the most common cutaneous condition seen in individuals infected with HIV. Other cutaneous disorders appear only when the CD4 count usually less than 200 cells per micrometer. Included in these disorders, eosinophilic folliculitis or hairy leukoplakia, or bacillary angiomatosis and Kaposi sarcoma. Systemic sclerosis, amyloidosis, and Fabry's disease, also many dermatological manifestations can be aided for the diagnosis. Systemic sclerosis may be divided into two disparate types: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. The prognosis of limited cutaneous systemic sclerosis is generally good. Diffuse cutaneous systemic sclerosis has a worse prognosis because of a higher incidence of internal organ involvement, including the kidneys. Other skin changes pose forms of systemic sclerosis, including hypopigmentation, hyperpigmentation, alopecia, cirrhosis of the skin, and telangiectasis and pruritus. Amyloidosis, which results from the production and the extracellular deposition of an abnormal fibers protein that has been specific characteristic. Amyloidosis may be a systemic condition or strictly cutaneous condition. Cutaneous manifestation including macroglossia, pinch purpura. Amyloidosis due to the deposition of beta-2 microglobulin can also develop in the setting of dialysis, causing carpal tunnel syndrome and the bone cyst. This is a Fabry's disease showing multiple angiokeratomatosis, and this is the characteristic eye signs for amyloidosis. What about dermatological manifestation of uremia? Many of the dermatological manifestations associated with uremia, such as pruritus, cirrhosis, are prevalent in interstitial disease population, but are not specific for uremia. Other manifestations, especially those related to dialysis procedures, including calcinosis coitus, calciphylaxis, Curl's disease, Paul's disease of dialysis, nephrogenic fibrosis epidermolysis associated with gadolinium MRI. Significant cirrhosis occur in about 90% of dialysis patients as an etiology of decrease in water content in the epidermis, or decrease in sweat volume, or atrophy of the sebaceous gland, or result from uremia-induced alteration and corneocyte maturation. Some patients may develop ichthyosis. The prevalence, the perceived roughness may, many patients respond actually to the use of emollients. Pruritus is a very common, affecting CKD and interstitial disease with high prevalence. Pruritus may be relieved with the initiation of dialysis. However, pruritus more commonly begin approximately 6 months after initiation of dialysis and typically increase with the length of time on dialysis. Pruritus may be episodic, constant, localized, generalized, may be mild or severe, well localized the forearm and the upper back predominantly are affected. Pruritus frequently affects the patient's sleep pattern and psychological well-being. Continuous manifestation of pruritus, including exudations, prurigo nodularis, and lichen simplex chronicus. Some proposed cause of uremic pruritus, including cirrhosis, hyperparathyroidism, hypercalcemia, hyperphosphatemia, or elevated histamine level, increased dermal mast cell proliferation, and uremic sensory neuropathy. The management included emollient, augmentation of dialysis, normalization of serum calcium and phosphorus, and parathyroidectomy indicated. For some patients, sedating, antihistaminic, and sauna therapy. The usage of ultraviolet phototherapy has a role. The usage of cholestyramine and acrylic charcoal also. Some clinical studies have suggested that opiate receptor antagonists like naloxone maybe have a role for the management. Pigmental alteration we have are present in around 25 to 70% of dialysis patients, pallor-associated anemia, a brown to slate gray discoloration may occur as a result of urinary deposition in association with iron overload from excessive blood transfusion, a yellowish hue, which has been attributed to the retained urochromes and the carotenes which are deposited in the epidermis and subcutaneous tissue. A brownish hyperpigmentation is common mostly in the sun-exposed distribution. The hyperpigmentation results from an increased melanin production because of an increase in a poorly dialyzable beta melanocyte stimulating hormone. Alopecia probably is more common in incisional disease than in the general population. Likely causes of alopecia in this disease include systemic lupus, chronic telogen effluvium. Chronic telogen effluvium may be related to commonly used medications such as heparin, antihypertensives, and lipid-lowering agents. Uremic frost actually didn't see it. And lastly, because of the early initiation of dialysis, this is first described in 1865, and they actually present when the urea blood urea natural is very high, as you see, and the evaporation results in deposition of urea crystals in skin that dissolve with water. Porphyria cutanea tarda are poorly dialyzed. Plasma porphyrins are poorly dialyzed and are elevated in most patients on dialysis. A bolus disease that is clinically similar but metabolically distinct from Porphyria cutanea tarda has been described in the dialysis population. True Porphyria cutanea tarda also has been reported to occur in patients on dialysis. Excessive transfusion may result in considerable iron overload, which can contribute to the significantly to the development of obesity. Arterial steal syndrome, where prolonged ischemia will affect the limb, will result in digital gangrene, peripheral neuropathy, and cutaneous atrophy. Individuals at heightened risk for this complication include those patients with peripheral vascular disease and diabetes mellitus. Dermatological disorders associated with renal transplantation. Renal transplantation are functions of immunosuppressive medication prescribed as well as immunosuppressed condition produced. Immunosuppressive medication reduce cell-mediated immunity and augment the potential for malignant transformation. Studies have shown that 50 to 100% of renal transplant recipients have transplant-related cutaneous complication. Factors such as time after transplantation, geographic location, climate, and skin type greatly modify the clinical disorders associated with renal transplantation. Medication-related disorder is famous with cushingoid changes, with the development of monofacies, cervical fat, cutaneous finding, including striae distance, cutaneous atrophy, and telangiectasis. Hypertrichosis occur in about 60% of patients, may be associated with the development of keratosis pilaris. Acne develop in 15% of patients and primarily affect the cheek and back. Most severe in the first year, acne later improve with the reduction of corticosteroid use. Disorders of pilosebaceous unit may result from cyclosporine and corticosteroid use. including acne, folliculitis, hypertrichosis, keratosis pilaris, sebaceous gland hyperplasia, and epidermal cyst. Gingival hyperplasia, which occur in about 1/3 of patients receiving cyclosporin therapy. The iatrogenic induced decrease in cell-mediated immunity predisposes the renal transplant patient to infection by a variety of organisms. Renal transplant patients are heightened risk for developing opportunistic infection during the first 6 months after transplantation because of the use of higher dose immunosuppressive agent. Continuous manifestation is crucial in surveillance of opportunistic infection because cutaneous lesions frequently are the first sign of disseminating disease. Mycobacterial infection, patient may develop infection with a variety of acid-fast bacilli, specifically typically or atypical mycobacteria. Histopathological examination and tissue culture are necessary to make the correct diagnosis. Therapeutic option of this infection including antimicrobial, surgical debridement, and reduction of immunosuppression drugs. Immunosuppression-related fungal infection, it raises versicolor, has been shown to be the most common fungal infection and occur in 80 to 48% of renal transplant recipients, which is higher than found in the general population. Pityrosporum yeast has been shown. As regards immunosuppression-related fungal infection, we have pityriasis versicolor has been shown to be the most common fungal infection and occur around 18 to 40% of renal transplant recipients, which is a higher rate than that found in the general population. Pityrosporum yeast has been shown to be also occur more prevalent than in the general population. We have also dermatophytosis, although common after renal transplantation, but is no more common than in the general population. Immunosuppression-related viral infection, we have human papillomavirus, cutaneous viral infection, which with a prevalence of around 50% after the first year and up to 90% after the 5th year. Common and the plant warts, which predominant occur most frequently in sun-exposed areas, usually are multiple in human papillomavirus type 1, 2, 3, and 4 are found most commonly. However, many types, also 16, 18, 5, and 8, have been reported in association with a variety lesion in renal transplant recipient, which usually associated with epidermal dysplasia verruciformis. Eradication of human papillomavirus is difficult. Treating the warts aggressively and early with the usage of cryotherapy, electron coagulation, and the carbon dioxide laser, surgery and radiotherapy are not more effective and may result in scarring. Oral and topical retinoids have no option, but imiquimod, an agent that enhances immunity by upregulation interferon, has a limited role. Immunosuppression-related malignancy, primary cutaneous malignancies are more common after organ transplantation. The incidence of non-melanoma skin cancer is 20 to 40% of times than in the general population. The cumulative risk of cutaneous malignancy is around 10 to 30% after 5 years, up to 10 to 44 at 10 years, to 30 to 40% at 20 years. The prevalence of skin cancer varies according to the geographic location and the amount of ultraviolet exposure and the predominant skin type. Most malignancy occur in sun-exposed areas and are usually found in the head, neck, and upper extremities. Management of non-melanoma skin cancer include sun avoidance, broad-spectrum sunscreens, early detection of malignant and precancerous lesion, and aggressive therapy. Complete surgical excision with a margin control is necessary. Adjuvant radiotherapy chemotherapy may have a role. Also, some studies have shown that immunochemo to be safe and effective for superficial basal cell carcinoma and actinic keratosis. Immunosuppression-related malignancy, we have squamous cell carcinoma with a prevalence around 50 to 250 times more frequent in individual and general population, And the basal cell carcinoma also 6 to 10 times more frequent in renal transplant recipient than in the general population. Actinic keratosis also occur at a younger age and develop a faster rate in renal transplant recipient. Actinic keratosis frequently have more severe cytological atypia and may have a more rapid progression to squamous cell carcinoma. Clinically, it may be difficult to distinguish actinic keratosis and subcutaneous cell carcinoma, and worse, keratoacanthoma is also encountered. The development of Kaposi sarcoma in renal transplant recipient is associated with human herpes virus 8. A mucocutaneous lesion occur in 60% of renal transplant recipient with Kaposi sarcoma. However, visceral disease is not uncommon. Therapeutic option is very painful because we have to stop immunosuppressive drugs and with the adjuvant usage of radiotherapy, chemotherapy, excision, and cryotherapy. Melanoma occur 2 to 9 times more frequently in the transplanted population than in the general population, according to the population registry data and the published studies. Studies are conflicting regarding the prognosis of melanoma in the transplant recipient, including the risk of recurrence of melanoma following transplantation, malignant fibrous histiocytoma, atypical fibroxanthoma, and dermatofibrosarcoma protuberance have been reported in renal transplant. Several cases of Merkel cell carcinoma occurring in renal transplant recipient have been reported. Most lesions develop on the head and the neck or the extremities. Overall mortality of Merkel cell carcinoma is around 35%. Lymphoma are the second most common malignancy in the transplant recipient. We have cutaneous T-cell lymphoma, cutaneous B-cell lymphoma, more common in the transplanted population. Also, we have porokeratosis, disorders of the epidermis keratinization has been reported as an unusual manifestation of immunosuppression in solid organ recipient. Several of the clinical variants have been reported, including disseminated superficial porokeratosis, single lesion of porokeratosis of Mebelli, and disseminated porokeratosis of Mebelli. In conclusion, cutaneous involvement is common in many kidney disorders. Careful skin examination in chronic kidney disease patient may be a valuable aid in diagnosis and the monitoring of therapy. Familiarity with the skin signs of systemic diseases which may cause chronic kidney disease and the possible dermatological complication of interstitial disease and renal transplantation is essentially to maximize early diagnosis and proper management of these disorders. That's it. Thank you.
talk. As regard audience, please don't forget to submit your questions to be discussed at the end of sessions. Thank you all.
Thank you very much. And we are still running in the more elected sessions here for Professor May Hasballah. She is coming now with a talk that is one of my favorites. Professor May Hasballah is a well-known figure in nephrology. She is a professor of internal medicine, Cairo University. Professor May is the vice chair of the Egyptian University Hospital Committee as well. She is Professor May is the president-elect of the Egyptian Society of Nephrology as well. Professor May will talk about one of the major concerns in hemodialysis, especially in incident dialysis patients, and what is the risk. Please go ahead, Professor May.
Thank you very much, Professor Hisham, for the introduction, and I also would like to thank Professor Magdi Sharqawi for inviting me to share in this prestigious conference and for choosing this very important topic. I will try to keep the best in young dialysis patients, and of course, the pediatric, if you consider the pediatric age group to include those below the age of 18 or 19, including adolescent patients, and or most of the adolescent patients, which considering to reach to the age of 21. So this is somewhere between the pediatrics and adult populations. So the agenda will include mortality risk in hemodialysis in young mortality using the machine learning approach, the role of LDH and RDW, role of vascular excess, and the difference between pediatrics and adults, and then implications in clinical practice. So both adult and pediatric patients on chronic hemodialysis have a higher risk of mortality compared with patients benefiting from early kidney transplantation. You can see here the survival of those on transplantation in red as compared to those on dialysis. And while the risk factors of mortality in chronic hemodialysis are known to differ between pediatrics and adult populations, risk factors are not well understood in young patients who started dialysis in childhood. You can see here the difference between the survival in those on hemodialysis as compared to those in the normal populations, and also those on hemodialysis have a lower survival advantage as compared to those who start on peritoneal dialysis. There is an increased mortality in children selected to start hemodialysis rather than peritoneal dialysis, and the hemodialysis-associated mortality is particularly high during the first year of dialysis, in children starting dialysis at an older age, and in children with a short time under treatment by the nephrologist before dialysis. This may reflect a delayed referral or maybe the aggressiveness of the kidney disease. Mortality risk differs between hemodialysis and peritoneal dialysis. It varies over time. The survival advantages, especially there in the first 2 years, and that's because of improved preservation of the residual kidney function, which is a very important factor in the general well-being and mortality, whereas as the time goes by, there is deterioration of the peritoneal membrane, and this reduces the dialysis adequacy and potentially increasing the mortality risk. So we have to identify the factors where some of them are unmodifiable, including age less than 5 years, for instance, and you can see here we can compare those patients who started dialysis below the age of 5 years, down there, compared to those who started dialysis at an older age. Also, female, gender, and African American origin, and the etiology of renal disease, whether it's a GN disease, whether it's primary or secondary, or whether it's a non-GN disease. You can see here there is variations in survival according to the etiology. Also, we have the comorbidities related to the cardiovascular risk, and this is a very well-known graph where you can see here the upper lines are those on normal populations, males and females, compared to those on dialysis, and you can see the difference in survival, especially so in early age, in the first column, the early age. You can see the marked difference between survival on those on hemodialysis as compared to the normal populations. But then we have potentially modifiable factors that we can work on, including the underweight and obesity, malnutrition, anemia, hemodialysis dose, fluid overload, hypertension, and vascular excess. And of course, we need to have markers in order to identify all these factors, and maybe multi-marker approaches which can improve the predictive ability of all-cause mortality beyond the established risk factors. A combination of albumin and high-sensitive CRP in patients on hemodialysis, for instance, or albumin and high-sensitivity CRP, white blood cells, and ferritin in patients on peritoneal dialysis. Now I'm going to speak about the key predictors of 5-year mortality using a machine learning approach, and this is a very interesting paper that was published this year, 2020, in Nephrology, Dialysis and Transplantation. And here it included 362 patients out of more than 2,500 patients. They were pediatric and young adults, starting dialysis before the age of 19 years, on thrice weekly hemodialysis, and with a minimum follow-up of 5 years since the initiation of dialysis, or death within 5 years. They were outpatient DaVita dialysis centers between the periods from 2004 to 2016, and the outcome was defined as the probability of dying on chronic hemodialysis within 5 years after the first dialysis, corresponding to the interval in which 64% of deaths occur. 100 variables were studied, out of which only 12 variables were retained in the final analysis, allowing a prediction of 5-year mortality with an accuracy of 81%. These are the variables, these are the 12 variables, and they ranked according to importance. And actually, these variables are markers of malnutrition, inflammation, anemia, cardiovascular changes, and dialysis treatment. And it was found that the most important predictor was the hypoalbuminemia, but also the low weight for age and decreased albumin globulin ratio and decreased serum creatinine were among the other variables. Well, actually, albumin is a marker of both inflammation and malnutrition, and as I mentioned, it was reported to be the most important predictor of 5-year mortality. It's also a major predictor of mortality in adult population. And partial dependence plot suggests a threshold of 4 grams per deciliter, and albumin and dialysis dose have been reported to be highly related in other studies. As I mentioned also, low normal albumin globulin ratio could also be interpreted as a marker of malnutrition. Normalized protein catabolic rate has been suggested as a better nutritional marker than albumin in pediatric dialysis patients, but it was not retained as a predictor of mortality in many reports. In elderly hemodialysis patients, serum albumin levels was considered independent factor of 6 months mortality, in addition to other factors, including age more than 75 years and other comorbidities. Now, the next risk factor was found to be the reduced lymphocytes, which was always correlated with the increase in neutrophils. And lymphocytopenia is also a marker of malnutrition and a surrogate of recurrent infections, and it can indicate previous immunosuppression therapy for underlying kidney disease, increasing the risk and pathologic metabolic changes. Lymphocyte indices like neutrophil lymphocyte ratios and platelet lymphocyte ratios can also be regarded as markers of malnutrition and inflammation and mortality. In other studies, CRP is frequently elevated in dialysis patients with a very strong negative correlation with markers of nutritional status. Now we come to the markers of anemia, and these were extensively studied and were found to have low hemoglobin, less than 11 grams per deciliter, reduced red blood cell count, and high red blood cell distribution WETs. And actually, this is increasingly recognized as a predictor of all-cause and cardiovascular mortality, and as a more important risk factor than the traditional markers of anemia. Also, low serum iron was traditionally a predictor of early 3-year mortality. Now we have the cardiovascular changes, and increase in the systolic blood pressure was the risk factor, and this is a nice marker. Hypertension, as a known risk factor of left ventricular hypertrophy and cardiovascular morbidity, is expectedly associated with mortality, but it was the post-dialysis systolic blood pressure that was more strongly associated with mortality than the pre-dialysis blood pressure. Well, it could also be expected to have a low blood pressure as a risk factor, but actually this relationship which occurs in adults was not found in pediatrics. There is no pediatric data about this U-shaped relationship between the blood pressure and mortality. Now we come to the dialysis treatment, and here we have the KT/V and the reduced ultrafiltration rate, which was mostly associated with decreased dialytic weight gain. Low ultrafiltration rate of less than 10 milliliters per kilogram per hour is reported to be associated with an increased risk of mortality. So children may require higher fluid intake to meet their nutritional needs and growth, and higher rates of fluid removal may indicate better achievement of nutritional goals. And higher ultrafiltration rates may also improve convective removal of larger uremic solutes that are associated with cardiovascular disease and mortality. For the dialysis dose, it is the KT/V, and considering the post-dialysis urea rebound, so higher KT/V 1.4 are commonly targeted than in adults, which is a minimum of 1.2. And there was an association of KT/V of less than 1.5 and increased mortality, while delivering higher values did not appear to provide any additional benefit. And there was also an association of KT/V and less than 1.6 and nutrition in terms of normalized protein catabolic ratio. And therefore, the ideal KT/V 1.5 is of 1.5 to 1.6 may thus be proposed for patients starting hemodialysis at an adolescent age. Now, this is the 12th marker, which is the LDH, and this will take us to the role of LDH. It's recently been reported to be the second most important predictor of mortality after low serum albumin, and this is indicative of the relevance of blood membrane interactions, maybe organ malperfusion and metabolic changes during chronic hemodialysis treatment. And let me again tell you about the increased red blood cell distribution, WETs, which is also a new risk factor that was identified to be potentially more important than the low hemoglobin. And this increased RDW reflects an increase in heterogeneity in the size of the red blood cells due to impaired erythropoiesis, transfusions, or hemolytic anemia. So it's very easy to measure these simple variables that may give us a clue, an early clue to the risk factors of mortality that we can maybe intervene early enough to prevent this possibility. So what about the role of vascular access? And of course we know that patients who started hemodialysis with central venous catheters have significantly higher all-cause mortality, whether it's a central venous catheter only or a combination of arteriovenous fistula or graft plus a central venous catheter. And of course, this may have to do with association with enhanced inflammatory state in these patients. Actually, this is one of the early predictors of death on dialysis, as the first 90 days after initiation of dialysis is a period of especially high risk of death, and central venous catheters is one predictor of death, as well as low body mass index, which is a surrogate of malnutrition, and lack of attendance at a nephrology clinic prior to commencing dialysis. Now, what's the difference between pediatrics and adults? And well, diabetes and dyslipidemia appear to play a minor role as predictors of mortality in pediatric hemodialysis patients when compared to adults. And being growers, pediatric threshold for albumin was suggested to be 4 grams per deciliter, which is higher than in adults of 3.45 grams per deciliter. And the U-shaped relationship between blood pressure and mortality has not yet proven in pediatric patients having a smaller blood volume. And higher ultrafiltration rates are used compared to adults. A low ultrafiltration rate of less than 10 mL per kg per hour is associated with increased risk of mortality in children, whereas a higher ultrafiltration rate of 10 to 13 mL per kg per hour in adults is associated with intradialytic hypotension and increased risk of cardiovascular morbidity in adults. Higher values of KT/V in children of 1.4 to 1.5 are commonly targeted than in adults of 1.2. And most of the studies in this regard were conducted in adult populations, so pediatric data are still limited. So finally, what are the implications in clinical practice? And we'd like to have a holistic approach and look at all variables that are related to as risk factors concerning dialysis, which is the bird's eye view. And this slide I actually borrowed from Professor Tarek Elbaz in one of his presentations on diabetes, and this really applies to many other things that we meet in life. So therefore, multimodal interventions beyond KT over V are needed to address all mortality-related risk factors, including malnutrition, inflammation, anemia, hypertension, besides the dialysis adequacy in this particular group of patients. And these factors are potentially modifiable by early detection, proper management, and delivery of adequate dialysis. And many easily available markers in clinical practice can be used as mortality predictors, and these markers could be used for surveillance and early alarming signs to pay attention for adequate early intervention. And early establishment of permanent vascular access instead of dialyzing through a central venous catheter is crucial. Adequate pre-dialysis follow-up of CKD patients is mandatory since it directly impacts dialysis mortality. Studies on pediatric hemodialysis patients are needed to fill the gap between pediatrics and adult data, and this will help us to investigate how monitoring of such simple markers may help to further enhance the management of nutrition, fluid anemia, with the ultimate goal of reducing mortality in children and young adults on chronic hemodialysis. And thank you very much.
Professor Dr. Maya Hasaballah, very elegant, very informative and illustrated. I think it's one of the magnificent talks in this Congress. And coming to our next speaker, Professor Cherry.
First, I would like to thank Professor Dr. Hisham Sayed for allowing me to be here today as a chairperson in the annual dialysis conference. And now I'm going to present Professor Dr. Charles Swanepoel. He's an emerite associate professor of nephrology in the University of Cape Town in South Africa. He is currently the president of the African Society of Nephrology. He has contributed significantly to the development of guidelines for the management of CKD and AKI in South Africa, and has many publications in many various international journals of nephrology. He is also the medical advisor of Fresenius Medical Care in Cape Town in South Africa. He's going to talk about CKD MBD updates. So would you please go ahead, Professor Dr. Charles?
Good afternoon, everyone. I'd like to thank the organizing committee for inviting me to the 12th annual Egyptian Dialysis Conference. I'm sorry that I'm not able to be there with you today, and I'm sure that the conference is going to be a great success. I've been asked to give an update on mineral bone disorder in CKD. This talk will be a reminder, a bit of revision, some new information, and anecdotal cases. Some of you may have seen these slides, some of the slides before, and I apologize for that, but maybe the revision is therefore not out of place on the slide. There are only opinions that treating calcium, inorganic phos, and PTH to certain targets would improve the risk of cardiovascular disease. We don't have any randomized controlled studies to show that this is a fact. But does the COSMOS study qualify? COSMOS study was published in NDT in 2015. It involved 6,797 patients from 20 European countries over a 3-year prospective follow-up with 28,167 observations. Unfortunately, 26% died. These, I believe, fulfill Hill's criteria for the minimal conditions needed to provide evidence of a causal effect between incident factors and consequences. I draw your attention to the graphs that I've taken from this paper. On the upper left side, you get serum phosphorus, where the nadir is 1.42 millimoles per liter, and you can see that the hazard ratios increase on either side of this figure. So mortality increases the lower one goes or the higher one goes. The same applies to serum calcium with the nadir here of 2.2. And finally, the same with serum PTH, with the nadir being 398 picograms per mol. Serum phosphate is a predictor of all-cause and cardiovascular mortality, but it is, however, a poor indicator of phosphate balance in CKD patients. KDIGO 2017 produced this clinical practice guideline update, and all the KDIGOs I mentioned from now onwards will come from 2017. And yeah, they suggest that lowering the elevated phosphate towards normal is what one should be aiming for in stages 3A to 5D. And make the point that there's an absence of data supporting that efforts to maintain phosphate in the normal range are of benefit. They do say treatment should be aimed at avert hyperphosphatemia. How does one lower phosphate levels? Well, there's dialysis, and there's some modalities of dialysis that are said to lower phosphate more than others, but we won't be talking about that. There are phosphate binders, and then there's diet. High phosphorus foods are, in the center, those sausages. They are absolutely jam-packed full of phosphate, full of preservatives. Processed foods, cheese, hamburger, all have got high content of phosphate, which is rapidly absorbed, almost 100% absorbed. Note the others. Meat, it's about 60% absorbed, and so on. So check to see what your patients are eating, and check to see what you're eating, particularly as this affects normals as well. The phosphate binders too have been disadvantaged by having observational studies with their use only. The COSMOS study assists us with a realistic target of 1.4 millimoles per liter, which, as you saw, is related to outcomes if the figures are much higher or lower than 1.4. And then to make the point again, hyperphosphatemia must be corrected to at least prevent the clinical symptoms, itching and bone disease. This KDIGO group also suggested that we should restrict the dose of calcium-based phosphate binders, not only the dose, but also maybe if one can, avoid calcium-based phosphate binders. However, most of Africa can only afford calcium carbonate. The others are far too expensive. This was a gem of a study, published in Kidney International from Munro Peacock's group in Indianapolis. Studied 8 patients. And what he did was, he looked at oral calcium carbonate in stages 3 to 4 chronic kidney disease. It was their patients who were randomized, as you can see, to 500 milligrams of calcium 3 times a day and to placebo. After 3 weeks, there was a washout period, and then once again, the crossover study, the placebo received the calcium carbonate and vice versa. This was a full balanced study, measuring urine and feces, as well as calcium kinetics using radiotracer calcium. What did they find? Calcium carbonate supplementation produced a positive calcium balance, but did not affect phosphorus balance. The calcium kinetics demonstrated a positive net bone balance, but this was less than the overall calcium balance. suggesting that there was soft tissue deposition. Bad news. Why are phosphate binders not taken? This is something I'm sure you all come across. I certainly do. 38% of people forgot to take it at least once a week. But look at other reasons. Forgetting is one of them, as we mentioned. Too many, it's also a problem. Swallowing problems, taste, and not effective. So we must look at all this when we treat our patients. It's not a benign disease. What is the diagnosis? Typical livedo reticularis pattern with these ischemic skin lesions. This is a longitudinal section of capillary taken from a calciphylaxis area. Notice the mountains of calcium that has deposited in this vessel with very little opportunity for blood to flow through the lumen. If one can obtain clinically usable sodium thiosulfate, it apparently dissolves these crystals with great healing. I unfortunately am unable to obtain the clinical variety, only the industrial variety. The spine. One of my patients with hyperparathyroidism on cinacalcet, because she didn't want to have a parathyroidectomy, developed spinal cord compression symptoms. And this was the scan showing this lesion at around about T8, which we, in discussion with the radiologist, we ultimately decided was a Brown's tumor. I went and I Googled Dr. Google and looked for other similar pictures and came across this very same one, a very similar one, sorry, which was definitely a Brown's tumor as well. So it can cause cord compression and can be quite disabling. What is a Brown's tumor? Well, it's actually an osteoclastoma. This is bone blue, osteoid seam pink, osteoblast on this side with that very small thin calcification front. But if you look at the bone on the left side, you can see osteoclasts with very small, indistinct little blue lines of fibrosis caused by PTH stimulating fibroblasts. This then will develop into that osteoclastoma if it's not controlled. Very excellent paper. Haven't got time to go into this slide in detail. I advise you to look it up. Mark Verflut, Kidney International 2017. Calcium and phosphate in the bloodstream of both patients and us with initial passive deposition. But what also happens is Phenytoin A, which is a calcification inhibitor, will mop up the calcium and phosphate crystals. However, in chronic kidney disease, we know that all these inhibitors of calcification are diminished, as is Phenytoin A. So once it's overwhelmed, the calcium phosphate crystals develop into primary calciprotein particles, CPP, and secondary calciprotein particles, CPP. These are also a test that you can use, a functional test, which measures the time point of conversion from primary CPP to secondary CPP in the serum. Why do we want to measure this propensity time? Well, if you look at this diagram, you'll see that the primary CPPs move up and on to develop the secondary CPPs. But we know that the secondary CPPs are highly toxic to vascular smooth muscle cells. So we try and keep it at the primary CPP level for as long as possible. How can we do this? Obviously adding Phenytoin A, albumin, magnesium, and to maintain a high pH. If you shorten this time, in other words, develop secondary CPPs far more quickly by adding phosphate, calcium, and as we know, there are no inhibitors or very few or diminished inhibitors in CKD patients, and having a low pH. Another study published this year looked at the association of serum calcium protein particle size as well as the transformation time, together with arterial calcification, as well as mortality. And they looked at that number of incident hemodialysis patients, and were able to show that in incident HD patients, neither the CPP2 size nor T50 was associated with prevalent arterial calcification and stiffness. It may be that the study was not long enough, and that with time these things would change. But they did see that larger CPP2 was associated with risk of mortality. In patients with CKD, what is the optimal PTH level? It's not known. However, KDIGO suggests that progressively rising or persistently elevated above the upper normal limit be evaluated for modifiable factors, vitamin D, calcium, and phosphate. The treatment, however, should not be based on a single elevated level. This is a slide that you've seen before, showing the mortality increasing as PTH on this axis in picograms per mil diminishes or decreases, or as it increases, mortality will increase as well. So hazard ratio high on either side of this range of PTH. The study coming from the Gulf Cooperation Council countries show the same U-shaped PTH mortality relationship of less than 300 or more than 450. The Gulf data fits in very nicely with this graph that I've shown you before, in that their range is between 300 and 450 approximately before mortality increases on either side of that range. Also another gem of a paper, Mo, haven't got time to go into it, but just to mention, if you look at the bone drawing on the left of the slide, you can see that both low turnover and high turnover disease would increase your calcium and your phosphate. And as we mentioned, these then affect the vascular smooth muscle cells, change the phenotype into osteochondrocytic like cells, which then are able to calcify and in fact form bone in vessels. So Mo, Jason, 2008, well worth reading. The dreaded vascular calcification, a aorta of a patient. Well, vitamin D. Vitamin D can be activated by many extrarenal cells. And in so doing, this has led to recommendations that native vitamin D supplementation should be addressed in patients with CKD. We all know this formation of the active vitamin D from dehydrocholesterol in the skin. But what is little known is that once the vitamin D is hydroxylated in the liver, there is a feedback mechanism, a negative feedback mechanism in the liver, which will prevent further vitamin D from being hydroxylated until the stores of vitamin of 25 are used. So there's a protective mechanism if we use natural vitamin D. This is the study which looked at two arms, cholecalciferol arm and a placebo arm in patients with stages 3 to 4 CKD. What I want to point out to you is the cholecalciferol arm, the PTH over this period of 12 weeks remained totally stable. Also 125 increased over this period of time in the cholecalciferol group. In the placebo group, PTH went up to 15.2 and the 125 stayed the same. I'll point out that both calcium and phosphate in both arms were unaffected. So cholecalciferol is safe and it stabilizes your parathyroid hormone. And all these figures were statistically significant. So what do they conclude? They conclude that vitamin D insufficiency should be addressed before calcium-based binders are used, provided that you use cholecalciferol and don't use the active vitamin D analogs in CKD patients with secondary hyperparathyroidism. But watch the PTH level. You may well have to use active vitamin D later on. Calcium, what does KDIGO say? They just say suggest avoiding hypercalcemia. Cosmos is the way that's the way I do go, and I suggest you all go. 2.2 millimoles per liter. Children try and keep it the same range, and don't use high dialysate calcium concentrations. So what are the future trends? Note, pay more attention to the foods that we and our patients eat. A relatively calcium-free environment is ideal. If you can, avoid calcium-based phosphate binders. Use natural vitamin D early on in the course of progressive CKD before using the active variety. Monitor the trends in biochemical changes. And the Cosmos study has given approximate values for the biochemical targets. And these are the values that I tend to use in my practice. Thank you very much for your attention.
thanks to Professor Swanepoel for excellent talk. And now we will shift to the discussion.
Thank you very much, Professor Ashraf, and thanks for all our elegant speakers today. I believe that there is a lot of discussion. We will concise about some of them. We will start for Professor Ghunaymat, who is unfortunately is offline for an emergency consultation. We hope that everything will be correct. The audience is asking a very important question that we already highlight in our Egyptian guidelines. The question is, does it make difference to obtain CBC before or after dialysis? The answer, yes, it differs according to the volume of fluids during ultrafiltration. So in this issue, we do recommend, as in general clinical practice, to do CBC pre-dialysis in the mid-week dialysis session. So it makes difference, but according to the guidelines and the standard of investigation is to do the CBC pre-dialysis, preferably in the mid-dialysis week session.
Now we second questions for Dr. Tariq Tantawi. Please, Dr. Tariq.
I'm with you.
Okay. Someone said that he asked about calciflaxis treatment, the ideal treatment.
Actually, with a proper care for calcium, phosphorus, parathyroid hormone, we actually don't see this hard complication now. The role of parathyroidectomy has a role in case of severe secondary hyperparathyroidism, or the usage of sodium thiosulfate has a role also in the clinical status. Actually, before we shifting to the diagnosis of calciflaxis, we have to be properly diagnosed because there is over diagnosis in that situation, and the higher prevalence of calciflaxis in cases in elderly, diabetic, and obese. We have to follow this issue properly.
Please, Dr. Tariq, may I ask you a question about treatment of pruritus?
Yes. You come to a very hot and a very common issue during our daily practice about pruritus. Actually, we have two sectors as regard proper dialysis and adequate dialysis. And when we override this condition, we have to use it emollient, sedating antihistaminic, or the use of sauna, or usage of shortwave ultraviolet. There is role also of some medications like naloxone, as I mentioned in my presentation.
Thank you.
You are welcome.
In continuing to your perfectly answered, Professor Tariq, I just highlighting that sodium thiosulfate in some countries are aided to the dialysate solution for preventive or for management of calcific uremic arteriopathy. Although the literatures and the researches in this field is not too much, but we all aware that calcific uremic arteriopathy or calciphylaxis is one of the bad prognostic signaling for patient survival. Going to the dialysis in pediatrics, Professor Dr. Mary Hasaballah had highlighted a lot of issues. We will concern about few questions just to inform the audience about that. I fully agree that the pediatrics needs more attention in the management, and we don't share the adult with the pediatrics simply because if we are going to share between them, we have to realize that surface area should be better than the per kilogram. In ultrafiltration, in KT over V, we should refer to surface area. Even in population with hemodiafiltration, we should also as well. So per kg formula should be referred to surface area. So I am kindly asking Professor Dr. Amai, can you please more information about the paradox of ultrafiltration, which is critical in pediatric if below 10, which is safer in adult if below 10. So this is a paradox just to be clarified.
Yes, I think you touched a very important point. It's really a paradox. It's exactly the opposite. In children, we don't, the low ultrafiltration rate of less than 10 mL per kg per hour is associated with a risk factor for mortality, and exactly the opposite in adults. If you have more than 10 to 15, it's a risk factor with hypertension. So what is said about the adults is that they're growers and they need to have more fluid intake to meet their nutritional requirements, and this ensures that they have met the target of the nutritional requirements, and maybe there is also will be increasing in convective force and removal of more toxins. But I agree with you, Professor Hisham, this needs to be further studied, because with studies on this group of patients, the young adults and pediatrics, that's still lacking is not up matching to the adults. So this definitely needs to have more studies and study for the surface area and maybe the blood volume. So this is very important to do, really.
Thank you very much. I was just adding, if you allowed me, that in pediatrics there is as well inflamed aging, which is a common manifestation in adult, but it starts even in pediatric population. So sharing the same pathology of diseases in CKD and on dialysis between adults still a cornerstone in that. And going on that field, we need more literature on pediatrics to be in our scope as well, to learn from their side. Coming to the CKD MPD, I think one of the best here, Chairman Professor Ahmed Adam, can handle the questions.
Thank you very much. However, Charles, how are you? So, are you with us?
I'm okay, thank you very much, and you?
Yeah, I'm fine, thank you. I got a difficult question for you, sir.
Can I answer it, you mean?
Yeah, of course you can. All right, I have a problem with the practical guideline about levels, because
Yes.
Can you help us, or help me in particular, in the best level before starting management, and if the levels is related to the staging?
نعم
Are you with me?
هقول لك ده لك برايتس كمان
Sorry, I can't.
I'm sorry, we have technical difficulty here. All right.
Okay,
I will
okay.
re-say the question. Difficult in the level and the practical management according to the level and staging about calcium, phosphorus, PTH, and vitamin D. And just to
Yes.
give you an example, PTH maybe 180 picogram in stage 5 may be considered accepted, but in stage 3 may be high. And the same as phosphorus, maybe 4.5 in stage 5, may be very high in stage 3. And the second related question, when you must do vitamin D25 assay, and related to this, when you must start 125 vitamin D, or you are going to keep it till the end stage 5 with hyperpara.
Okay, well, you know, the problem, one of the issues that I try to highlight is that one must follow trends, not just individual levels. And if you follow the trend and you notice that your calcium is falling, as you pointed out, which is a very good question, your calcium levels begin to fall and your phosphorus levels start to go up. That is the time that you must intercede, because when that happens, that's when PTH really will become a problem. You can't control your PTH at that stage, and you have to correct the calcium and phosphate. What I'm advising, and I've showed you that study from Monroe Peacock, is that you try and do it very gently in stage 3 and going into 4, 3B4. And the one way that you can do it is by introducing cholecalciferol. And I showed you that study that compared cholecalciferol with placebo, and how you can control the PTH, can control the calcium, and it doesn't increase phosphate absorption. So trends, I can't give you an exact range, and that's one of the problems we have. We don't know what the exact ranges are that we want to target. Cosmos has given us a rough idea, I think. So calcium of 2.2 millimoles, I'm sorry, you need to transfer that into milligrams, and phosphorus into 1.42 millimoles. That's the sort of figures around which I play with. But once again, it's not, there are no studies showing that that's ideal. Cosmos has given us an idea, and I think a lot of what came out of KDIGO was based on what Cosmos found. So I don't know if that answers that question. I think the important thing is to try and not to develop hyperparathyroidism to such an extent that you get, as we've just heard, calciphylaxis and all the other problems, the osteoclastomas, and I think it should happen early on, stage 3B4, and controlling it very gently with natural vitamin D. Natural vitamin D won't always control hyperpara, and that's been my experience. So then, that's when I introduce the active. In my case, we use 1-alpha. I'm sure you use the same in Egypt, and that's what I would do. But as you suggested, later on, when we can't control PTH and it becomes greater than those figures I showed you, 600 picograms per mil, all those figures where it really becomes bad news from a mortality point of view.
All right, thank you for the answer. I got actually 2 questions from the audience, but just back to my question. Do you have a cutoff level to start 1-alpha or 125 in your pre-dialysis patient? At which time? Because I believe that some of my junior staff using this 125 very great using, and it increase the calcification if it is used early.
Yes, as I say, I think if you can get your calcium level in the low normal range with cholecalciferol or ergocalciferol, depending on what you're using, if you can get it to the normal range of 2.2, and you're controlling your phosphate with whatever you're able to use. Can you use Sevelamer up there, or
yeah, we use Sevelamer. Yeah.
Okay, well, that's ideal. I mean, I think Sevelamer is a good agent. It's a bit expensive here in South Africa, so I use it very seldom. But if you can avoid overloading with calcium early on, I think that's the clue. And if you read the literature, there's no doubt that the calcification is a major problem. You saw that one slide from that I showed you from Mo in 2008.
Yeah.
Looking at the bone on the left, you saw that even in hypoparathyroidism, you cannot deposit calcium and phosphate into the bone, and that then goes into the tissues. So you've got to be very careful. You can't go too low and you can't go too high. And that really, at the end of the day, becomes the art of medicine. Because the science of medicine here has not given us an exact range. And the art of medicine then becomes your own experience and how you see what the patient's course is, looking at trends. And I'm sorry, I can't give you a more exact answer to that. We all struggle with this. It's always an uphill battle to get the phosphate under control.
All right, we can shift gear to a case or just a numerical case. A patient on your dialysis service, this is from the audience, with a high PTH, he didn't give the number, and low phosphate, didn't give the number, and low calcium, no numbers. But the question is how to manage, and he speculates the role of combining active and native vitamin D.
Right, so I think if he's on dialysis, it's really a late stage already. And I think that maybe at this stage one can introduce the active vitamin D 1-alpha 1-alpha, which then becomes 125. I say that because your calcium is low, so that will increase the calcium in the blood. Because your phosphate is low, that's very good. You don't have to worry too much about increased phosphate absorption, which the vitamin D will result in. And hopefully that combination of bringing up the calcium, keeping the phosphate low, will bring down your PTH level. In fact, you've got to do that before you consider anything else. Before you consider using cinacalcet to bring the PTH down, or parathyroidectomy. Because if at this stage, with the low phosphate and low calcium, one went ahead and used sine calcitor, a parathyroidectomy, it would be wrong, because you would then introduce an adynamic bone disease situation, which is the low PTH level, which is showed you on that slide, calcification of soft tissue. And in fact, the slide I showed you with the calciphylaxis lady, she had a parathyroidectomy and developed adynamic bone disease. And I'm sure and convinced that that was the reason that she ultimately developed the calciphylaxis that I showed you.
All right, I got another question, except if the panel have other question from the audience. He questioned about the use of teriparatide and donizumab in CKD patient for controlling CKD MVD. What's your expertise?
Well, you know, first of all, I've never used the IV preparations for vitamin D, so I don't have the expertise. I do know, however, it's supposed to be less producing hypercalcemia, although even that can be debated. Sorry, what was the other one?
Donizumab.
That's a very new one. I don't have any experience with that at all.
All right.
That's just come out, and I wait further studies. You know, the policy that I have is be not the first to start the new, but also not the last to throw the old away. So I want to see what happens with the new types. Maybe you can tell me. Have you got any experience with?
No, actually, I don't have any experience.
In tenofovir?
Yeah. Actually, I got, but I see if the panel have any more questions.
We use that tenofovir in Shams University in very infrequent cases. One of them was Paget disease and CKD, and it's diagnosed carefully. It's Paget disease and marvelously improved with denosumab. Sometimes we are using denosumab if there is intractable, non-modifiable by dialysate and management treatment with cerebral manifestation if the patient got severe hypercalcemia above 13. So those population of patients may be managed by denosumab in very, very selected cases, not on the guidelines, I think so.
Thank you for that. I mean, I have no experience with it, and I'll await further evidence and information. Is it very costly?
No, it's not costly, but very efficient, especially for patients. Marvelous response in severe hypercalcemia, intractable hypercalcemia by overdoses of vitamin D and calcium. We trying first to do the best by very low dialysate calcium and stopping all the medications, but in some cases there's cerebral manifestation of hyperviscosity by hypercalcemia. We use denosumab, within a week it drops it to the normal level.
Amazing, thank you. Amazing.
I believe we got another 2 minutes. If the panel wants, I got a question, but
I think I have a very important question to Professor Swanepoel, and I would like to thank you as well, not in this symposium, but for our on-air communication during the COVID-19 in Afrin. I would like to thank you very much on that. We changing our knowledge on that during the COVID-19 in Africa. So
thank you. I enjoyed the interaction.
I
learned
really
a lot.
the discussion with you on air.
Thank you.
I have here are questions. I would like to highlight on that because it's not confirmed, but it's promising. The value of vitamin K2 in CKD and mineral bone disease, and here I am saying that vitamin K2 not only in the calcific uremic arteriopathy or the warfarin induced, but in general practice with CKD mineral bone disease.
Well, thank you for that question. I mean, as you know, that one of the inhibitors is matrix glyprotein, and matrix glyprotein is in fact aided by the use of vitamin K1 and K2, and it then will obviously aid in the inhibition of calcification. There was a very good study looking at the use of vitamin K1 in a calciphylaxis case, and it cured the case, but it was one case only. There have been other studies looking at vitamin K use in stiffness and calcification, and the results haven't been all that encouraging. But you know, once again, it's minimal studies. We need more of them, more controlled studies. My view is that if it's needed for the activity of matrix glyprotein, I would certainly make sure that it is used or given. And you know that you can give it in the form of cabbage. Cabbage consists of a lot of vitamin K1. So it can be used in the diet, and I'm sure that our dietitian I see is due to speak soon, maybe talking about this. I don't want to preempt that talk. But in addition, there's fermented soya beans from Japan, apparently, that's got vitamin K as well, and apparently it's very nutritious. Although I'm not looking at it, I'm not too sure whether one would want to eat it. It looks very like fermented rotten vegetables. But so I think the evidence is not entirely there to support it, but I don't see any harm in using it in our patients.
Actually, I got a question, except if the panel have other questions. It is a very straightforward question, but maybe the answer may not be so straightforward. If you got a parathyroid adenoma which is active in a context of hyperpara, are you going to shift instantaneously to do parathyroidectomy, or try the medical treatment including calcium mimetic and different others? In your expertise, it is a hot nodule in the parathyroid.
Well, you know, one would be worried that it was a primary adenoma, and one would be worried that in fact nothing is going to suppress PTH secretion. So I would probably do a nuclear, and you've done a nuclear study. You've shown that this is, the others are suppressed, and the other three glands are suppressed, and this is one that's very active. Is that the scenario?
Actually, one of the surgeons from the UK does not like to do systemic scan before doing parathyroidectomy. I'm asking, do we have benefit of using medical treatment in treating secondary hyperpara? It is secondary rather than tertiary, of course, because tertiary we must remove the nodule. If there is a benefit from using medical treatment, or it is a waste of time?
No, there is great benefit. But let me just say that you've got to do the PTH, phosphate, and calcium thing first.
Of course we do, yeah.
Yeah. Okay. Then, if your patient, if a patient can afford it and it can tolerate it, cinacalcet is fantastic. It works very, very well. You may have to increase the dose, starting off at 30, going to 60, and ultimately to 90, which is what I've used in two of my patients. The one patient I showed you with the spinal cord lesion that we think is a Brown's tumor, she was on cinacalcet, and it didn't work, and we wanted to do parathyroidectomy on her, and she refused. So if you leave it too long, you can run into troubles, and so therefore I would suggest, if you're going to use cinacalcet, still watch your PTH levels. If you're not controlling it, then go for parathyroidectomy.
And coming to the last couple of minutes, we have a lot of questions. I will choose just very few from them for the lack of the time. We have a couple of questions, but with the same answer. One of the audience is asking about the FETWIN, and the other question is asking about the calproteins. So I will combine both questions with the same answer. FETWIN is one of the very important preventive for the calcific uremic arteriopathy. In our research, FETWIN is decreasing with the progress of CKD, and FETWIN is the scavenger for such calproteins to promote for inhibition of the calcific uremic arteriopathy. The last question is the difference in dialysis between the central venous catheter as well in the arteriovenous fistula. Does it make a difference? Yes, it makes a difference, because most of the central venous catheter had a recirculation of about 20%. But we have to remember that arteriovenous fistula has both arms, one arm to the right with the low flow arteriovenous fistula and recirculation of 20 and above % as well, especially with proximal stenosis, and on the left arm, very high arteriovenous fistula, more than 30% of flow of the cardiac outputs makes two complications. One is heart failure, and the second is the cardiopulmonary bypass, making dialysis adequacy questionable. So by the end of this session, I would like to ask very sincerely our very eminent speakers, as well chairpersons, as well our friends and colleagues online. Thank you very much.
Thank you very much.
Thank you.
Enjoy yourselves for the rest of the Congress. Enjoy yourselves.
Thank you, Charles.
Thank you.